Hi, my name is Bruno Scheller. I'm interventional cardiologist at Saarland University in the southwest of Germany and working for a long time in this field. So we have to a little bit look at different geographies and different operator experience, of course. In our lab, we started very early, end of the 2000s already, and learned a lot about lesion preparation over the years. And meanwhile, our strategy is to first do lesion prep in every lesion, independent of the patient or the anatomy, and deciding then, depending on the result of lesion preparation, if we treat this lesion with a drug-eluting stent or with a drug-coated balloon only. And this has led to a more than 50% coverage with DCB of all lesions. However, we have to be aware that in clinical reality, we have more complex disease. And this means we have a hybrid or blended approach in most of the patients. This means one lesion gets stented and longer diffused lesions are typically treated with DCB. So we have the focus has shifted from instant restenosis initially to treatment of de novo disease. And here we have at the moment the results of two large randomized trials. This is the RECAGE-3-1 trial and the Solution de novo trial. The RECAGE-3-1 trial showed overall a superiority of the drug-eluting stent over DCB in non-complex coronary lesions. So this means if we look in more detail in this trial, in the subgroups, small vessels, bifurcations, patients with diabetes or renal failure, there is, even in this specific situation, no significant difference between DCB and DES. The difference comes from the larger coronary arteries in this very simple lesions, and this is still the situation where a stent is unbeatable. The Solution de novo trial with more than 303,000 patients has been presented last year at the TCT meeting. We are still waiting for the publication, but overall it showed the non-inferiority of DCB-based approach against the drug-eluting stent-based approach. And this was a strategy trial. This means that it is accepted that some of the lesions have to be stented after lesion preparation. In this trial, this was in 20% of the cases given. On the other hand, 80% of the lesions could be treated by DCB only. So we have no specific trials investigating if there are specific subsets that may more benefit than others. But what we know is, of course, we have the data for the small coronary arteries in de novo disease. We started with the basket small 2 trial years ago, where we should show up to 3 years that there is no difference. And we have the patient-level meta-analysis, the Andromeda study, meanwhile, which has been published last year, where we see a reduction of MACE at 3 years when using DCB instead of drug-eluting stents in small coronary arteries. So I think this is an indication which is really proven. For other scenarios, I think our approach is what is proposed, that we will try to limit the number and length of stents. And this is possible if you prep every lesion very carefully and then decide upon, depending on the result of lesion preparation, which device to use. And this results typically in a reduction of stents by 70 to 80% in this indication. And I think that's the way to go. It's not the goal to replace stents, but to reduce the total number of it. So as said before, small vessels are given, but we have many other patient populations at higher risk, diabetics, for example, where stents do not that good as in simpler lesions. We have a huge number of patients with high bleeding risk features, where the goal is to limit the time of dual uncompleted therapy, for example. And so at the end of the day, it's the diffuse disease, the patient, where we can offer with the DCB an alternative to full metal jacket stenting. So in routine practice, if you start such a program, start it carefully. Do not things you do not feel comfortable with. And the very beginning is to try to relearn lesion preparation. This means to use NC balloons over semi-compliant balloons, switch to cutting or scoring balloons if it gets more complex, and follow all the rules for calcium modification techniques we have nowadays. And then do only cases where you have a really good result of lesion preparation. And if you get more experience, you can go a little bit more complex.